Hi, my name is Brian Morris, student physical therapist with Rocky Mountain University. The body region I'm going to be talking about today is the right shoulder. So my patient was a 63-year-old male. He was an engineer and he really liked exercising at the gym and for recreational activities. He also does a lot of home repairs with his wife. I think he mentioned them remodeling their house. And the examination was done on February 1st, 2013 with a referral for right shoulder pain and positional vertigo. Chief complaint was the right shoulder pain, and then he described the additional onset of mild positional vertigo over the last month. The shoulder was injured in November 2012, and the vertigo started around December 28th, 2012. Photo score was 51 with a predicted change of 18 within 15 visits. Looking at the body diagram, the cervical spine and elbow were cleared. The lumbar spine was also cleared. And the primary complaint of the P1 complaint of right shoulder pain was constant and variable. It was a dull ache that sometimes presented with sharp pain, particularly with in-range motion. Pain at worst was 6 of 10, and at best was a 4 of 10. The P2 of positional vertigo was also constant and variable, and he described it more as lightheadedness as compared to dizziness. The patient had no numbness or tingling down the arm, so radiculopathy was ruled out, and P1 was not related to P2. So when looking at planning for the physical exam, the joints under the area of symptoms, AC joint, GH joint, and SC joint were all considered. Brachial plexus for referral to that area was considered. Some of the contractile structures with the rotator cuff musculature, biceps tendon, coracobrachialis, upper trap, pec major and minor, rhomboids, and levator scap. Other structures to consider was the scapula, cervical spine, thoracic spine, acromion, clavicle, the ligaments of the glenohumeral joint, and glenohumeral labrum. So my early hypothesis at this point was a primary hypothesis of right shoulder impingement syndrome of the supraspinatus tendon, secondary hypothesis of partial tear of the rotator cuff supraspinatus tendon. Aggravating factors for P1 were reaching behind head and reaching behind back, shoulder flexion, shoulder abduction, and there was pain with these activities that were constant and variable depending on the range he was moving in. Easing factors for P1 were rest. He also received a cortisone shot from the physician that only provided about a week's worth of relief and didn't really give him much benefit. The P2 aggravating factors were laying down for extended periods of time and then getting up and sitting. Easing factors were kind of sitting there for a few minutes while symptoms subsided. So his history, his sleep and 24-hour pattern was he woke up a couple times, about 3 or 4 times a night, to change positions, and because he would end up on his right shoulder, and that caused pain. His mechanism of injury for the right shoulder was doing crunches at the gym. He described doing crunches and having his arms flexed to about 90 and holding each elbow with the opposite hand. And he was doing crunches and felt a sharp pain all of a sudden in his right shoulder that he tried to kind of push through because he thought the pain would go away. And pain continued to linger, and he had increasing pain over the first month, and now symptoms have kind of plateaued but are still lingering. The positional vertigo, he described standing up at Christmas and feeling lightheaded, and the symptoms stayed present for about 2 to 3 days before subsiding and only cropping up in the mornings when he wakes up. The progression, it's unchanged over the past couple months. He had The only significant prior history was elbow surgery in '95, but that's been followed and treated and has not caused any issues since. He, as described before, had a cortisone shot from the physician, but that did not provide any benefit, and this is his first time attempting conservative care. The medical history and comorbidities, review of symptoms, revealed high blood pressure, heart disease, a cyst in '71, right elbow surgery '95, left knee surgery in '88, and right hand Dupuytren's syndrome, and subsequent surgery in 2005. The red flags were dizziness, yellow flags were increased or high blood pressure and heart disease. The special questions that were asked really focused on the imaging. He had x-rays that were negative for fractures and really any other alarming conditions. His x-rays revealed no significant findings and everything seemed normal according to the x-ray. Here's a list of his medications that were reviewed. So subjective asterisk signs during the history that were picked up on for P1 were reaching behind the head, reproducing symptoms of 4 of 10 pain, and then reaching behind the back, which reproduced symptoms of about 2 of 10 pain, which was severely limiting his range of motion. Reaching behind the back was a little bit less than behind the head, but both reproduced symptoms. P2 asterisk sign was supine to sit, so laying down and then sitting up. The primary hypothesis after the subjective was still right shoulder impingement syndrome of the supraspinatus tendon, but after observing his sitting posture, I wanted to add, I thought that was due to a postural deficiency. Secondary hypothesis was still partial tear of the rotator cuff, supraspinatus tendon, with maybe some focal weakness of the scapula. P2 primary hypothesis was orthostatic hypertension from that high blood pressure, but I didn't want to rule out any vestibular issues such as BPPV. And then at this point, I was unable to rule out either primary or secondary hypothesis with the musculoskeletal impairment and the non-musculoskeletal vertigo. The severity of the condition was moderate. He had no real signs of anything serious going on as far as red flags. However, his pain got up to a 6 of 10 at worst with important functional tasks or activities that he does at home, and so that was kind of indicated more of a moderate severity. His irritability was also moderate. He had a dull ache with sharp pain at end ranges, inflection and abduction, and symptoms typically subsided when the shoulder fell below midline, but that dull ache was always present throughout the day. And the nature of the problem was pain that was coming from inflammation of that shoulder soft tissue. The stage of the disorder, symptoms started with a gradual increase in pain but have currently plateaued with no changes. The soft tissue of the shoulder seems to be in a subacute phase of healing. It's still inflamed and possibly because of that impingement on the acromion. The symptoms are stable and reproducible. They're constant day to day. Asterisk signs reproduce pain, and palpation within the physical exam, as we'll get into in a little bit, also reproduces pain. And then postural deficiency of forward head and rounded shoulders would exacerbate those symptoms of with the shoulder impingement. So planning the physical exam, I really wanted to focus on that the shoulder impingement primary hypothesis, and so the CPR special tests were going to be included, and then the CPR for full thickness rotator cuff also were considered. And then as far as the P2 vestibular system imbalance testing was something that I wanted to focus on. There was really no contraindications for any of these tests, and all tests were appropriate for the initial evaluation day. Precautions and contraindications. I really wanted to monitor the positional vertigo because I didn't want to aggravate these symptoms throughout the physical exam by having him lay down and sit up. Postural observations were discussed already, as well as asterisk signs, and then the joints above and below, as well as dermatomes, myotomes, and reflexes were cleared. The left active range of motion and passive range of motion were assessed first. Flexion was 160 on the left, which was a little limited. External rotation was 50. Passive range of motion was within normal limits. When looking at the right active range of motion, he was definitely limited with reproduction of those pain markers as well, but the right passive range of motion was actually within normal limits comparatively. And then moving on to the physical examination, palpation of the supraspinatus tendon reproduced P1 pain, posterior cuff reproduced P1 pain, spring testing of the upper thoracic spine revealed some hypomobility. Anterior humeral glide of the glenohumeral joint was hypermobile. Posterior humeral glide was hypomobile. And then some manual muscle testing was done of the right shoulder, and some of these muscles were strong but reproduced the P1 symptoms in the shoulder. Special tests performed were the drop arm test. That was negative for a rotator cuff. Painful arc sign was positive. The Hawkins-Kennedy impingement test was positive as well. And balance testing for the vestibular system actually came out negative. We had him stand, single leg stand, eyes closed. We had him walk, turning his head with his eyes closed. None of these tests really reproduced any of his lightheadedness. So when assessing the physical exam and formulating a plan, my primary hypothesis of right subacromial shoulder impingement syndrome with postural dysfunction was definitely my first thought and was confirmed with the physical exam, but the secondary hypothesis of the partial rotator cuff tear couldn't be ruled out. But with both of these, whether it was primary or secondary, the treatment plan will be pretty much the same, and it won't really affect how I treat. Primary hypothesis of P2 was orthostatic hypertension because all the vestibular testing was negative. Contributing factors was postural dysfunction, no predisposing factors, and then we've gone through the asterisk signs of reaching behind the head and back. Plan of care, I expect this patient to fully recover previous level of function. Probably be about 6 to 8 weeks. We'll see him about 2 times a week. And his specific goals are regaining his functional ability with overhead tasks, and preparing for discharge. I want patient to be pain-free with asterisk signs, as well as pain-free with his range of motion, flexion, and abduction comparative to the left side. If there's no progress being made, modifications to the plan of care and manual treatment will be reassessed. And then if that doesn't change any of his symptoms, he'll be referred back to the primary physician for a consult and possible right shoulder rotator cuff repair. When looking at my plan of care, based on all the subjective and objective portion of the examination, it'll consist of manual therapy for passive range of motion, posterior and inferior glides, mid-thoracic manipulation, seated, specific strengthening and neuro re-education exercises, postural reinforcement, active assisted range of motion, and patient education. And that's it, and thank you for listening to this case presentation. Thanks.